Welcome to Euboxia. This is a series about one thing: never missing a diagnosis because you forgot to look for it. Episode 1 is electrolytes. The numbers you see on every single patient, every single day, and the numbers that, when you get them wrong, kill people quietly and quickly. Over the next hour, we're going to take the 6 major electrolytes and put each one inside a box. A fixed, repeatable way of thinking that works at 3 in the morning when you're tired and the patient is crashing. Let's get started. So what does euboxia actually mean? It's built from 2 Greek roots, eu, meaning good, and box, the framework. Good boxes, good thinking inside defined limits. And that word choice is deliberate, because the whole philosophy here pushes against something we glorify in medicine: the brilliant diagnostician who pulls the rare answer out of thin air. Euboxia argues the opposite. Most misdiagnoses aren't missed because they were exotic. They're missed because nobody looked systematically. Every clinical problem has a defined space of possible answers. That's the box. Thinking inside, it means being systematic, not creative. Each disorder we cover follows the same 3 questions. What is it? Why did it happen? And what do I do? Same structure. Every time. Electrolytes today, then acid base, then coagulation in later episodes. The goal isn't speed, and it isn't being the smartest person in the room. It's structure. Because structure is what's still working when you're exhausted and brilliance has left the building. Here are the 6 we'll work through, and their normal ranges. Sodium, 135 to 145. Potassium, 3.5 to 5. Calcium, 8.5 to 10.5. Magnesium, 1.7 to 2.2. Phosphate, 2.5 to 4.5. And chloride, 98 to 106. Memorize these cold because the entire diagnostic process starts with a single judgment. Is this number outside the box? Here's a pearl that runs through this whole episode, though. These 6 don't live in isolation. They're a network. Magnesium controls potassium. Calcium and phosphate are locked in an inverse dance. Sodium is really a water problem wearing a salt costume. You'll see, again and again, that fixing one number requires fixing another one first. Keep that in mind as we go. Sodium. Normal range, 135 to 145. We're starting here for a reason. Sodium is the most common electrolyte disorder in hospitalized patients, and it's the one where rushing the correction can do as much harm as the disorder itself. Here's the single most important reframe before we dive in. Sodium is not a salt problem. It's a water problem. Almost every time. Hold on to that. Sodium below 135. Hyponatremia. Before you do anything, run the box. And the box starts with osmolality, not volume. This trips people up constantly. First question: what's the serum osmolality? If it's above 295, you've got hypertonic hyponatremia, and your culprits are hyperglycemia, or an osmotic agent like mannitol, or contrast pulling water into the vascular space and diluting the sodium. That's not a sodium problem you fix with salt. You fix the glucose. If osmolality sits in the normal band, 280 to 295, think isotonic hyponatremia, and that's usually pseudohyponatremia from sky-high lipids or protein. It's a lab artifact. We'll see a whole case on this. The real disease lives below 280. Hypotonic hyponatremia, true hyponatremia. And only now do you ask the second question: what's the volume status? Hypovolemic points you toward vomiting, diarrhea, diuretics, or burns. You've lost salt and water and replaced with water. Euvolemic is the SIADH family. Also hypothyroidism and adrenal insufficiency, which people forget. And hypervolemic is the edematous states: heart failure, cirrhosis, nephrotic syndrome, where total body water is up, even though effective circulating volume feels low to the kidney. Here's why the order matters. If you skip straight to volume status without checking osmolality first, you will treat a glucose problem or a lab artifact as if it were SIADH. And the next case in this series shows you exactly how a patient gets hurt doing that. Osmolality first. Always. Now treatment. And this is where the box has teeth, because the danger here isn't just the low sodium, it's how fast you fix it. Split your patient into two worlds. Acute, meaning under 48 hours, or symptomatic with seizures or coma. That patient needs 3% hypertonic saline, 100 to 150 milliliters as a bolus, repeated if seizures continue, aiming to raise sodium just 4 to 6 points fast. That small bump is enough to pull water out of swelling brain cells. This patient lives in the ICU. The other world is chronic, over 48 hours, or asymptomatic. And here, speed is the enemy. Correct by no more than 8 points in 24 hours, and never cross 10 to 12. For SIADH specifically, fluid restrict to 800 to 1,000 milliliters a day, salt tabs if needed, tolvaptan as a specialist option, and always hunt the trigger. Now the red box, osmotic demyelination syndrome. This is what happens when you overcorrect chronic hyponatremia. The brain, which spent days adapting to a low-sodium environment, gets the rug pulled out from under it, and myelin in the pons literally ruptures. Your highest-risk patients are alcoholics, the malnourished, the hypokalemic, those with liver disease, or anyone with a sodium under 105. Here's the part people don't know. If you realize you've overcorrected, it's not over. You can actively relower the sodium with D5W or DDAVP and rescue the patient. Two formulas to keep handy: corrected sodium for hyperglycemia and the infusion rate equation. But honestly, the formulas matter less than the rule. In chronic hyponatremia, slow is safe and fast can be fatal. Now, we leave the algorithm and go to the bedside. 3 real ICU scenarios, 3 completely different mechanisms, but every one of them ends in the same danger zone. Case 1, the septic trap, SIADH, driven by the ventilator and opioids. Case 2, the false alarm, a sodium that looks terrifying but is a complete illusion. And Case 3, the overcorrection, a textbook rescue that goes catastrophically wrong overnight. As we walk through each, I want you to do the thing this series is built around. Stop and run the box before you hear the answer. Let's start with the septic trap. Meet Mr. K. 67, diabetic, chronic kidney disease, admitted to the ICU 2 days ago with urosepsis and intubated on arrival for respiratory failure. He's on norepinephrine, a fentanyl drip, midazolam, and piptazo. He's had 6 liters of normal saline since admission. On admission, his sodium was a perfectly normal 136. Now, 48 hours later, 119. His measured osmolality is 248, so this is genuinely hypotonic. And here's the clincher. His urine osmolality is 485, far higher than his serum, and his urine sodium is 68. His kidneys are aggressively concentrating urine and holding on to sodium at the exact moment his blood is screaming dilute. One more detail buried in the nursing note. He was agitated overnight, pulling at the tube, so the fentanyl got doubled at hour 36. Now stop and think. How big is this drop, and how fast? What category of hyponatremia is this? What's driving it? And there's more than one thing. And critically, the day team wants to give a liter of normal saline to replace losses. What do you tell them? Hold your answer. We'll break it down next. Let's open the box. The diagnosis first. Sodium fell from 136 to 119, 17 points in 48 hours. That's acute severe hyponatremia. It's hypotonic, osmolality 248, and he's euvolemic on exam. The urine osmolality of 485, towering over a serum of 248, tells you the kidneys are inappropriately concentrating, and the urine sodium of 68 confirms the renal handling is intact. Put it together, this is SIADH. Now the part that makes it an ICU case, there isn't one cause, there are 6, all stacked. Positive pressure ventilation reduces venous return and triggers ADH release. Fentanyl is a potent ADH stimulator, and notice the sodium fell fastest right after the dose doubled. Midazolam does it too. Pain and agitation drive ADH. Sepsis itself releases ADH through cytokines. And then, 6 liters of saline gave him the water load to express all of it. Now the trap, and this is beautiful and lethal. Giving normal saline to an SIADH patient doesn't raise the sodium. It lowers it. Here's why. His urine sodium is 68, but saline delivers a sodium of 154. His kidneys excrete the salt but cling to the water, so you're left with net free water retention and the sodium drops further. This is the desalination trap. In SIADH, when urine sodium exceeds serum sodium, saline behaves like a hypotonic fluid. So the correct move, fluid restrict to 5 to 800 milliliters, strip away the ADH drivers, wean opioids, treat pain without them, optimize the vent, and cap correction at 8 points per day. And do not reach for 3% saline here, despite that scary number, because he has no neurologic symptoms. This is a chronic-style correction. Check sodium every 4 hours. Case 2. Miss A, 54, severe necrotizing pancreatitis, ICU day 9. She's intubated, on low-dose pressors, and critically, she's been on lipid-rich TPN since day 3 because of an ileus, plus a propofol drip, which remember is delivered in a 10% lipid emulsion. 2 days ago, her sodium was a clean one, 38. This morning, it's 124. But here's the thing. She's not more confused, no edema, no signs of overload. Her measured osmolality? 282, essentially normal. Her triglycerides come back at 1840, and the lab phones to say the plasma sample looks milky. When you calculate her osmolality from the sodium, glucose, and BUN, you get 266, but the measured value is 282. That gap of 16, where normal is under 10, is a flag waving in your face. Now stop and think. The resident wants to fluid restrict and send a urine sodium. Should she? What is actually going on here? And how would you prove it? And what's the corrected sodium really telling you? Think it through. His is pseudo-hyponatremia, and the sodium of 124 is a lie. Here's the mechanism, and it's a measurement problem, not a physiology problem. Flame photometry and indirect ion-selective electrodes measure sodium across the total plasma volume, water plus lipid. Normally, plasma is about 93% water, so that's fine. But flood the blood with triglycerides, and that fatty phase displaces the water. Sodium only lives in the water phase, so when there's less water per milliliter of plasma, the machine reports a falsely low number, even though the concentration in the water itself is perfectly normal. The tells were all there. A normal measured osmolality of 282 means she's isotonic, so this can't be true hyponatremia. The osmolol gap of 16 flagged extra unmeasured stuff in the sample, the lipid. And the milky plasma was the lab handing you the diagnosis. Her true sodium is around 136 to 138, right where it was. She is completely fine. How do you confirm? Run a direct ion-selective electrode on an undiluted sample that measures sodium in the water phase only and gives the true value. As a rough rule, every 1,000 milligrams per deciliter of triglyceride above normal drops the measured sodium by about 2 points. Now the trap, and it's dangerous. The team fluid restricts, sends a urine sodium that comes back looking just like SIADH, and starts circling tolvaptan, all in a pancreatitis patient on pressors who actually needs volume. Fluid restriction here could tip her into shock. The error was trusting the sodium without ever checking the osmolol gap or glancing at the sample. Pearl, lipemic sample, near normal osmolality, gap over 10. Request a direct electrode before you treat. And in the ICU, anyone on propofol plus TPN, check those triglycerides. Case 3. And this one hurts. Mr. D, 48, alcoholic cirrhosis, child Pu-C, admitted with spontaneous bacterial peritonitis and hepatic encephalopathy. Day 1. Sodium 108, encephalopathic, but no seizures. The team does everything right at first. Cautious correction, fluid restriction, plus a small dose of 3% saline, target raise of 6 points in the first day. By hour 20, sodium is 116. Right on target. Everyone relaxes. Then, at hour 22, he starts pouring out urine, 800 milliliters an hour, and the urine osmolality crashes to 65. The night team, who don't know the case, read this as dehydration and give a liter of normal saline. They also see bloody-looking urine. It's not blood, it's just concentrated. And the intern gives desmopressin to slow the urine down. By hour 28, sodium is 131. That's a 23-point rise in 28 hours against a target of 6. Then, hour 32, dysarthria, dysphagia, gaze palsy, and flaccid quadriparesis evolving over 4 hours. CT shows no bleed. Stop and think. What happened? Name every error from hour 20 on. What's the diagnosis? And what will the MRI show? And is there anything you can still do? Let's dissect the errors, because each one is a teaching point. Error 1, at hour 22. That flood of dilute urine wasn't a problem. It was the kidneys auto-correcting. Once the SBP was treated and the hypotensive stimulus resolved, ADH switched off, and the kidneys started dumping free water on their own. A urine osmolality of 65 is maximally dilute urine. That's ADH, completely off. It was a good sign, and it got read as a catastrophe. Error 2, giving normal saline into that moment. The patient was already autocorrecting. Adding sodium when the urine is maximally dilute means essentially all of that sodium goes straight into raising the serum level, pouring accelerant on a fire. Error 3. And this is the fatal one, giving desmopressin to reduce urine output. Now, desmopressin was exactly the right drug. It clamps down on water excretion. But it should have been given prophylactically at hour 22 to stop the overcorrection. Given there, alone, without the saline, it would have saved this man. Instead, it arrived at hour 28, after the saline had already shoved sodium to 131. Too late, and now it just locks in the damage. Error 4, no monitoring. A patient, starting at 108 under active correction, needs sodium checked every 2 hours, not every 8. The team didn't even know overcorrection was happening until the brainstem started failing. 4 errors. 1 overnight, in the highest risk patient imaginable. Alcoholic, malnourished, cirrhotic. Sodium under 110. Every box on the risk list ticked. The diagnosis is osmotic demyelination syndrome. The MRI will show T2 and flare hyperintensity in the central pons, central pontine myelinolysis, and possibly extrapontine sites like the thalami and basal ganglia. The pathophysiology is elegant and tragic. In chronic hyponatremia, the brain protects itself by exporting organic osmoles to avoid swelling. Correct the sodium too fast, and that gradient violently reverses. Water rushes out of brain cells faster than they can pull those osmoles back in, and the myelin tears. A bit of history worth knowing. This was first described in 1959, classically in alcoholics and the malnourished, exactly this patient. Now the hopeful part. Yes, there's a rescue, if you catch it within the first day or two. Stop all sodium-containing fluids immediately. Give desmopressin, 2 to 4 micrograms IV every 6 to 8 hours, to switch ADH back on and hold water. Give D5W to actively bring the sodium back down. Target relowering by 8 to 10 points back toward 120, and monitor every 1 to 2 hours. Neurologic recovery is genuinely possible if you act before the demyelination completes. The prevention list is your permanent rulebook. Cap correction at 8 points a day in chronic cases, 12 absolute maximum. Check sodium every 2 hours in high-risk patients. Give desmopressin preemptively if they start auto-correcting. Keep D5W at the bedside, and read this twice, brief the night team. The pearl ties it together. Desmopressin is both the rescue and the prevention. Use it as the brake, while 3% saline is the accelerator. And remember where this patient was lost. In hyponatremia, the handover is where patients die. Let's pull the three together, because side by side, they teach the whole chapter. Case 1, the septic trap, SIADH, from the ventilator, opioids, and sepsis. The sodium fell from 136 to 119, real and acute. The clue was urine osmolality far above serum. The trap was giving saline to replace losses, which worsens SIADH through desalination. The rule, saline plus SIADH equals the desalination trap. Case 2, the false alarm, pseudohyponatremia from massive lipids on TPN and propofol. The sodium read 124, but the true value was 136. The clue was a normal measured osmolality, an osmolol gap, and a milky sample. The trap was fluid restricting a patient with completely normal tonicity. The rule, check the osmolol gap before treating any low sodium. And case 3, the overcorrection, ODS in a high-risk cirrhotic. Sodium shot from 108 to 131 in 28 hours. The clue, polyuria and dilute urine, signaling autocorrection, was missed by the night team. The trap was using desmopressin to chase urine output instead of to stop the rise. The rule, desmopressin, is both prevention and rescue, and brief every single team. 3 mechanisms. 1 danger. Same box. Here's the checklist. 6 boxes. Work through everyone before you treat any low sodium in the ICU. Box 1. Is it real? Check the measured osmolality and the osmolol gap, and if the sample's lipemic or the patient's loaded with protein, get a direct electrode. Rule out the illusion before you act. Box 2. How fast did it fall? Under 48 hours is acute and lets you correct faster. Over 48 is chronic, cap at 8 per day, and if you don't know the onset, treat it as chronic. Box 3. What's the tonicity? Above 295, hypertonic. Think glucose and mannitol. 280 to 295, isotonic. Think pseudo. Under 280, that's your true hyponatremia. Move on. Box 4. What's the volume status? Hypovolemic, euvolemic, or hypervolemic? Use the exam plus urine sodium and urine osmolality. Box 5. What's driving ADH? In the unit that's pain, opioids, the ventilator, nausea, hypovolemia, a long list of drugs, sepsis, and CNS pathology. Find them and remove them. Box 6. Is this patient high risk for demyelination? Sodium under 105, alcoholic, malnourished, liver disease, low potassium. If so, cap correction at 6 to 8. Keep desmopressin and D5W ready. Monitor every 2 hours and brief the night team. 6 boxes. Memorize them. I'll flip the coin. Sodium, above 145, hypernatremia. And here's the single sentence that unlocks all of it. Hypernatremia is always a free water deficit. Always. Either the patient is losing water they can't replace, or they can't physically get to water. Notice who's at risk. It's anyone who can't drink to their own thirst. The intubated, the demented, the very young, the very old. A normal awake person almost never gets seriously hypernatremic because thirst is a brilliantly powerful drive. So when you see it in a conscious patient, ask what's broken with their access to water. The causes: insensible losses from fever or burns, diarrhea, osmotic diuresis, diabetes insipidus, central or nephrogenic, inadequate intake, or someone pushing hypertonic fluids. The diagnostic box runs on urine osmolality. Above 800 means the kidney is appropriately concentrating, so the water's being lost somewhere extrarenal. Below 300 with a hypertonic serum means the kidney is failing to concentrate. That's diabetes insipidus. In between is partial D, I, or a mix. And the desmopressin test separates central from nephrogenic DI. Central responds, nephrogenic doesn't. Treatment: calculate the free water deficit, 0.6 times ideal body weight, times the ratio of sodium over 140-1, and replace it slowly, over 48 to 72 hours, with D5W or oral water. Central D, I gets desmopressin. Nephrogenic D, I gets counterintuitively, thiazides, and a low-sodium diet, and the Pearl, which mirrors hyponatremia exactly. Correct too fast, and you cause cerebral edema, because the brain generated idiogenic osmoles to survive the hypertonicity, and now you're flooding it. Aim for no more than about half a point per hour. 3 more cases, same format, different mechanisms, audience participation, run the box before the answer. These hypernatremia cases are, in my experience, where good nurses and good doctors get caught by good intentions, protocols followed correctly that do exactly the wrong thing. Watch for that theme. A thirsty brain after head trauma, a tube-fed patient slowly drying out, and a diabetic whose sodium hid behind his glucose. Let's go. Mr. T, 29, motor vehicle crash with diffuse axonal injury, GCS6, intubated, neurosurgery co-managing. ICU day 3, previously stable. Then overnight, his urine output explodes, 450 milliliters an hour, 2.7 liters in a single shift. He's sedated, so he can't tell anyone he's thirsty. The nurse, following a standard replace output cubic centimeters for cubic centimeters protocol, matches every milliliter with normal saline. Morning labs, sodium 168, serum osmolality 348. And the urine, osmolality of 78, specific gravity 1.002, urine sodium of 12. He has no IV free water running and no desmopressin ordered. Stop and think. What's the diagnosis and what lab pattern nails it? Why is replacing that urine with normal saline actively making him worse? And what do you order in the next 5 minutes? This one moves fast. So should you. This is central diabetes insipidus. The pattern that confirms it: a urine osmolality of 78 against a serum osmolality of 348. The kidneys are making maximally dilute urine in the face of extreme hypertonicity, the exact opposite of what they should do. A normal kidney here would crank urine osmolality above 800 to claw back water. 78 means ADH is simply absent. The mechanism: the head injury disrupted the hypothalamic pituitary axis. ADH production failed. The collecting ducts went impermeable to water, and free water poured straight into the urine. You confirm with a desmopressin challenge. Give it. And if urine osmolality jumps more than 50%, it's central. No response means nephrogenic. Now, why is the saline making it worse? Normal saline carries a sodium of 154. His urine sodium is 12. He's excreting nearly pure water, and the team is replacing it with concentrated salt. So every liter swapped drives the sodium higher. The correct replacement is free water, D5W, to match what he's actually losing. His free water deficit calculates to roughly 9 liters. Replace it over 48 hours, dropping sodium no more than 10 points a day. The trap, stated plainly, using saline to replace DI urine is one of the most common and most dangerous errors in the unit. The nurse followed a replace output protocol without anyone considering the electrolyte content of what was lost versus what was given. That's the lesson. Protocol-driven care without pathophysiology kills. So the orders: desmopressin now, D5W to replace the deficit and ongoing losses, target under 10 points a day, sodium every 2 hours, urine output hourly, and call endocrine. The pearl: in any TB patient with polyuria, check the urine osmolality before you order a drop of replacement. Miss R, 72, ischemic stroke with dysphagia, ICU, day 8. PEG tube placed on day 4. She's on a high-calorie, low-volume formula, 1.5 calories per milliliter, running at 60 milliliters an hour. Her free water flushes are, quote, per nursing protocol, 4 times 30 milliliters, so 120 milliliters a day. No IV fluids. She's febrile at 38.8, tachycardic and confused, though confusion is her stroke baseline. Sodium was 138 on admission. Day 8, it's 158. Her urine osmolality is 820. Urine output, a meager 35 milliliters an hour, dark and concentrated. Do the water math. The formula and flushes give her about 1,150 milliliters of free water a day, but a febrile, hypermetabolic patient is losing closer to 2,000 or more through insensible routes alone. Stop and think. Why is she hypernatremic? And what's the free water deficit? The urine osmolality is 820. Does that mean the kidneys are failing? And how do you fix this, including what you change in the feed orders? The arithmetic tells the whole story. Water in, about 1,000 from the formula itself, plus 120 from flushes. Call it 1,150 milliliters. Water out, insensible losses near 2,000, boosted by fever, plus urine around 800, roughly 2,800 milliliters. That's a deficit of about 1,700 milliliters every single day, compounding for 8 days. Her current free water deficit calculates to around 4.5 liters. And here's the key insight from that urine osmolality of 820. The kidneys are concentrating perfectly. They are doing their job flawlessly. The problem was never renal. The problem is intake. Not enough water went in. Treatment: replace the 4.5-liter deficit over 48 hours, about 96 milliliters an hour of D5W, or as flushes. Then, crank the free water flushes from 120 up to at least 400 to 600 a day. Consider a lower osmolality formula. Treat the fever to cut insensible loss. Monitor sodium, cap correction at 10 a day, and this is the fix that prevents recurrence. Document explicit free water orders rather than leaving it to protocol. The trap, that 4 times 30 flush regimen, is designed for tube patency, not fluid balance. In a febrile ICU patient, it's wildly inadequate. Nobody ran the water math, and she slowly desiccated over 8 days with completely normal-looking vital signs. The pearl: always calculate free water balance in tube-fed patients, and add 200 to 300 milliliters per degree of fever. Mr. P, 58, poorly controlled type 2 diabetes, admitted with an NSTEMI and cardiogenic shock. He's on pressors, his insulin drip is being run poorly, and his glucose sits between 380 and 420 all day. Urine output is a brisk 280 milliliters an hour. The whole team is focused on the heart. Nobody's watching the sodium. On admission, his sodium was 138, but glucose corrected, that's really 145. Day 2. As the glucose partially comes down to 280, the sodium reads 154, and the team is pleased. Sodium's rising appropriately. But correct that 154 for a glucose of 280, and the true sodium is over 158. His BUN is climbing. He's 5 liters positive, and his urine osmolality of 640 with that output screams osmotic diuresis. Stop and think. What's wrong with sodium's 154? We'll just give fluids. What's the true corrected sodium telling you? And what's the mechanism here? And how do you manage it? Potassium. Normal range, 3.5 to 5. If sodium is the electrolyte that hurts the brain, potassium is the one that stops the heart. The therapeutic window is narrow and unforgiving in both directions, and the lab value can lie to you through hemolysis on the way up and through cellular shifts on the way down. Respect this number. Let's build the box. Potassium below 3.5. Start with the 3 buckets of cause. GI losses, vomiting, diarrhea, fistulas. Renal losses, diuretics and hyperaldosteronism. And redistribution, insulin, alkalosis, beta agonists, driving potassium into cells without any true deficit. Poor intake alone rarely does it. And then the one everybody forgets, which will hammer all episode, hypomagnesemia, the cause of refractory hypokalemia. On the ECG, watch the progression, flattening T waves giving way to U waves, ST depression, a long QU interval, then PVCs and worse. And here's a danger flag. Low potassium dramatically potentiates digoxin toxicity, a combination we'll see kill someone 2 cases from now. Treatment scales with severity. Mild, 3 to 3.5. Oral potassium chloride. Moderate, oral plus IV if needed. Severe, under 2.5 or symptomatic, IV potassium chloride, but mind the ceilings. No more than 10 milliequivalents an hour peripherally, 20 centrally, because faster than that and the infusion itself can be arrhythmogenic. And the rule in the box, always replace magnesium first. Finally, a tool worth knowing, the transtubular potassium gradient. Take urine over serum potassium divided by urine over serum osmolality. In hypokalemia, a value above 7 means the kidney is wasting potassium. Diuretics, RTA, hyperaldosteronism. Below 3 means the loss is extrarenal, GI, or intake. It's a quick way to figure out which direction your potassium is leaking. 3 hypokalemia cases coming up. Same drill, different mechanisms, audience participation. And notice as we go. In each one, the raw potassium number is almost a distraction. The real question is always why. Is this a true deficit, a shift, or a kidney that's bleeding potassium? Get the mechanism wrong, and you'll either chase a number you can't catch or overshoot into danger. A starving patient, a diuretic spiral, and a paralyzed young athlete. Let's go. Mr. A, 41, anorexia nervosa, body mass index, 13.2. Profoundly malnourished. Admitted by psychiatry for compulsory refeeding, sent to the ICU because his admission ECG showed a QTC of 520. Nutrition was started 48 hours ago, straight at the full target of 1,800 calories a day. His admission electrolytes were called borderline but acceptable. Potassium 3.2, magnesium 1.8, phosphate 2.8. Now day 2, he's weak, and telemetry is throwing frequent PVCs. The new labs, potassium 2.1, magnesium 1.1, phosphate 0.8, glucose 62, and the ECG now shows a QTC of 580 with a 6-beat run of non-sustained VT captured at 6:30 this morning. Stop and think. What syndrome is this, and what made potassium, magnesium, and phosphate all crash at the same moment? What's your immediate priority? The electrolytes, the ECG, or the feeds? And the dietitian wants to push on with full calories. What do you say? This is refeeding syndrome, and the simultaneous crash is the signature. In starvation, the body burns through intracellular stores while serum levels stay deceptively normal. The moment you feed, especially with carbohydrate, insulin surges, and insulin drives glucose into cells and drags potassium, magnesium, and phosphate in with it. All three plummet at once. So look at the damage. Potassium 2.1 with a QTC of 580 and a run of VT, that's a cardiac emergency, full stop. Magnesium of 1.1 is doing double harm. It blocks your ability to replace the potassium and independently stretches the QT. Phosphate of 0.8 is severe, and that matters more than people think. Phosphate is the backbone of ATP, so depletion means muscle weakness, risk of respiratory failure, even hemolysis. And the glucose of 62 is itself a refeeding feature from the overshooting insulin. Management, in order, magnesium first, 2 grams IV, because it's the prerequisite for fixing potassium. Then potassium, centrally, rate limited. Then phosphate. Stop the feeds. Continuous monitoring with a defibrillator at the bedside. Support the glucose. And when stable, restart nutrition at 10 calories per kilo per day, just a quarter of target. The trap was the very thing the dietitian wanted to continue. Full calories immediately. The nice guidance is clear. In the severely malnourished, start at 10 calories per kilo and advance over 7 to 10 days. Those borderline admission electrolytes weren't reassuring. They were the warning shot nobody answered. And the pearl, the rule for the whole episode: replace magnesium before potassium. Without magnesium, the sodium-potassium pump can't hold potassium in the cell, and your replacement just pours out in the urine. Miss E, 67, acute decompensated heart failure. On BiPAP, BNP 4200, frank pulmonary edema. She started on furosemide, 80 milligrams IV every 8 hours, and the diuresis is excellent. 4 liters negative in a day, lungs improving. Her potassium gets replaced with 40 milliequivalents of oral potassium 3 times a day. Day 2, potassium 3.1. They give more. 6 hours later, 3.0. Day 3, despite 120 milliequivalents replaced the day before, potassium is 2.6 and falling. And here's the kicker. She was started on digoxin this morning for rate control of new atrial fibrillation. Her other labs: chloride 88, bicarbonate 34, a metabolic alkalosis, magnesium 1.4. Her transtubular potassium gradient comes out at 12.5, markedly elevated. And the intern wrote, continue furosemide 80 every 8 hours. Stop and think. Why won't this potassium respond? And what is that alkalosis telling you? What does starting digoxin do to your urgency? And how do you break the cycle? Here's why you can't catch this potassium. Loop diuretics block the sodium-potassium 2-chloride transporter, dumping sodium, potassium, and chloride into the urine. And that drives a contraction alkalosis, which you can read right off her labs: bicarbonate 34, chloride 88. Now the alkalosis itself worsens the potassium, because as the blood turns alkalotic, potassium shifts into cells in exchange for hydrogen ions leaving. On top of that, low cardiac output has cranked up aldosterone, which tells the kidney to excrete even more potassium. Her transtubular gradient of 12.5 confirms profound renal potassium wasting. It should be under 3, when you're hypokalemic. And magnesium of 1.4 is quietly blocking retention. Bottom line, you cannot out-supplement an open furosemide tap. So break the cycle. Cut the furosemide dose. She's off BiPAP now. She doesn't need 4 liters a day anymore. And consider switching to torsemide for a smoother effect. Add spironolactone to block aldosterone and spare potassium. Give IV potassium centrally. Fix the magnesium first, as always. And the digoxin, hold it, or use extreme caution until potassium is above 3.5. Now the trap, and it's a genuine prescribing error, starting digoxin in a patient with a potassium of 2.6 on aggressive loop diuretics. Digoxin and hypokalemia are synergistically arrhythmogenic. Digoxin inhibits the very same sodium-potassium ATPase that low potassium has already crippled. The pearl, in anyone on digoxin, target potassium at 4 or above. The toxicity risk roughly doubles for every half point the potassium falls below 3.5. And in heart failure with hard diuresis, reach for a potassium-sparing agent early. Spironolactone and eplerenone earned mortality benefit in the RAILS and Emphasis trials anyway. Mr. C, 26, Asian, no medical history, collapses at the gym with acute bilateral leg paralysis after a heavy workout, and he'd eaten a big carbohydrate meal beforehand. He's alert, no pain. Blood pressure, 168, over 94, heart rate 118, a fine tremor in his hands. He denies any thyroid symptoms, says he's always been energetic. Potassium on arrival, 1.8. The team starts aggressive IV potassium, 80 milliequivalents, over 2 hours through a peripheral line. But look closer. His TSH is undetectable, under 0.01. His urine potassium is just 8, giving a transtubular gradient of 1.2. That is not renal wasting. So here's the paradox. A potassium of 1.8, profound, yet the kidneys aren't dumping any potassium at all. Then the nurse calls. After that 80 milliequivalents, the potassium is now 4.2, and the patient has rebound cramping. Stop and think. What does a gradient of 1.2 with a potassium of 1.8 mean mechanistically? What's the diagnosis, and what set it off? And what just happened with that rebound to 4.2? And why is it dangerous? Potassium above 5, and this is the one that can kill in minutes. First, always ask, is it real? Pseudohyperkalemia from hemolysis or a high platelet count is common, and you do not want to treat a lab artifact aggressively. Real causes fall into 3 groups: decreased excretion, acute or chronic kidney injury, Addison's, drugs, ACE inhibitors, ARBs, potassium-sparing diuretics, redistribution out of cells, acidosis, insulin deficiency, and cell lysis, rhabdomyolysis, tumor lysis, hemolysis. The ECG progression is your clock. Peaked T waves first, then a lengthening PR, then a widening QRS, then the ominous sine wave, then VF, or a systole. But here's the catch you must respect. ECG changes don't reliably track the potassium level. Some patients sine wave at 6, others look fine at 7. Don't be reassured by a clean tracing. Treatment is the classic 5 steps, and order matters. 1. Stabilize the membrane with IV calcium gluconate if there are ECG changes. This buys you minutes and does nothing to the actual potassium. 2. Shift potassium into cells. Insulin with dextrose, bicarbonate, nebulized albuterol. 3. Remove potassium from the body. Binders like patarimer, furosemide, or dialysis. 4. Monitor everyone to 2 hours. 5. Treat the cause. And the red rule, a potassium over 6.5 with ECG changes is an emergency. Give calcium first, before anything else, and do not wait for a repeat lab to confirm. Calcium doesn't lower the potassium. It keeps the heart electrically stable while your shifting agents go to work. 3 hyperkalemia cases, and these are some of the most dramatic in the whole episode. Because hyperkalemia is fast, and the mistakes that cause it are often a single order written without thinking about potassium at all. A paralytic that triggered cardiac arrest, a hidden endocrine collapse, and a cancer treatment that worked too well. Each one run the box. Let's go. Mr. B, 34, 45% body surface flame burns, day 12 post-burn. He's doing well surgically, multiple debridements done, hemodynamically stable, and he needs an urgent trip to the OR for skin grafting. The anesthesia team, covering today, is not his usual burn anesthetist. They plan a rapid sequence induction with succinylcholine at a standard dose. His potassium, before the procedure, is a normal 4.8. Succinylcholine goes in at 8:12. 2 minutes later, at 8:14, ventricular fibrillation on the monitor. Cardiac arrest. The stat potassium, drawn post-arrest, comes back at 9.1. ROSC is achieved after 4 minutes of CPR and 2 shocks. Afterward, the covering anesthesiologist says the potassium was only 4.8. They didn't know this was contraindicated. The primary burn anesthetist's response, succinylcholine, is absolutely contraindicated in burns after 48 hours. Stop and think. Why did that drug send potassium from 4.8 to 9.1 in 2 minutes? Where else is succinylcholine absolutely contraindicated? And with a potassium of 9.1 and ROSC, walk through the immediate management. The mechanism is upregulated receptors. Succinylcholine is a depolarizing blocker. It activates every acetylcholine receptor at the neuromuscular junction simultaneously. In normal muscle, that causes a modest, harmless potassium rise of half a point to a point. But a burn injury, after about 48 to 72 hours, triggers proliferation of extrajunctional acetylcholine receptors that spread across the entire muscle membrane, not just the junction. So now, succinylcholine opens channels across the whole surface of every skeletal muscle cell at once, and potassium floods out. 4.8 to 9.1 in seconds, straight into VF. And here's the brutal point. The pre-procedure potassium of 4.8 was completely irrelevant. Even a low normal potassium can kill this way, because it's the efflux, not the baseline, that does it. So memorize the absolute contraindications, because this is preventable death. Burns beyond 24 to 48 hours, crush injury and rhabdomyolysis, denervation syndromes like spinal cord injury, stroke, or Guillain-Barré after 72 hours, prolonged immobilization, and ICU myopathy, any existing hyperkalemia, malignant hyperthermia risk, and pseudocholinesterase deficiency. In all of these, use rocuronium instead, and you've got Sugamadex for reversal. The trap here is twofold. The information is in every anesthesia textbook, so it's a knowledge failure. But the covering anesthetist also didn't know the patient's burn day, so it's a handover failure too. For the potassium of 9.1 post-ROSC, calcium gluconate immediately to stabilize the membrane, ideally during the arrest, insulin and dextrose to shift, bicarbonate, nebulized albuterol, a binder for slower removal, continuous monitoring with potassium every 30 minutes, and emergent dialysis if it won't come down. Miss F, 61, rheumatoid arthritis on prednisone, 10 milligrams daily for 3 years, hypertensive on lisinopril, admitted for a total hip replacement. Perioperatively, the surgical team skipped her stress dose steroids. She's only on 10 milligrams. It's not much. Post-op day 1, she's hypotensive at 78/44, tachycardic, with a sodium of 128. Her potassium comes back 6.8, creatinine 2.4, up from a baseline of 1, glucose 62, and a random cortisol of under 3. Her ECG shows peaked T waves, and a prolonged PR. The surgical teams read, the low sodium is just from fluids. It'll normalize with hydration. The medicine consult gets called. And the lisinopril? Not held. It's her home medication. Stop and think. What's the one diagnosis that unifies the sodium, potassium, glucose, and cortisol? When the surgeons say, hold the steroids, she might have an infection, what do you tell them? And what 3 things do you do in the next 10 minutes? The unifying diagnosis is adrenal crisis, and once you see it, every number snaps into place. 3 years of prednisone suppressed her HPA axis and atrophied her adrenal glands. Surgery spiked her cortisol demand. With no stress dose steroids, the gland couldn't answer. Crisis. Aldosterone deficiency explains the low sodium, the high potassium, the hypotension, and the volume depletion. Cortisol deficiency explains the hypoglycemia and the failing vascular tone. And the lisinopril is pouring fuel on the fire. By blocking angiotensin II, it further drops aldosterone and worsens potassium retention, pushing it to 6.8. The peaked T waves and long PR are that potassium hitting the heart. It's a perfect storm, an aldosterone-deficient state, plus a potassium-retaining drug, plus surgical stress. Your 10-minute actions. 1. Hydrocortisone, 100 milligrams IV. Immediately. Do not wait for an ACTH stimulation test. 2. Calcium gluconate, to protect the heart from that potassium. 3. Hold the lisinopril. You never give an ACE inhibitor in adrenal crisis or hyperkalemia. Then a saline bolus, insulin and dextrose, to shift potassium and treat the hypoglycemia, monitoring, and fludrocortisone once she's stabilized. And when they say, hold the steroids for a possible infection, your answer is no. The infection, if there even is one, kills slower than the adrenal crisis will. The trap is that phrase, 10 milligrams isn't much. Anyone on systemic steroids above about 7.5 milligrams of prednisolone equivalent for more than 3 weeks has HPA suppression and needs stress dosing for surgery. It's on the pre-op checklist, and it was missed. The Pearl, the triad to burn into memory: low sodium, high potassium, low glucose, and hypotension in a patient on steroids means give hydrocortisone now, ask questions later. A random cortisol under 3 is diagnostic. Ister O, 52, newly diagnosed Burkitt lymphoma, high grade, bulky, and LDH of 4,800. He started R-CHOP yesterday, and oncology is delighted. The tumor's responding beautifully. But you get consulted today because his potassium is 7.2. His creatinine has jumped from 1.1 to 4.8, and his urine output has dropped to 18 milliliters an hour despite 3 liters of fluid. He's confused. His uric acid is 18.2, his phosphate 8.4, his corrected calcium a low 6.2, and the LDH is now over 12,000. The ECG shows a wide QRS and an emerging sine wave pattern with peaked T waves throughout. The oncologist says, give more fluids and rasburicase. The tumor's responding. Stop and think. A sine wave with a potassium of 7.2. What is your very first action? What is tumor lysis syndrome, and why are all these numbers deranged at once? And before you give that rasburicase, is there a contraindication you must check? Calcium. Total, 8.5 to 10.5. Ionized, 1.1 to 1.35. And that distinction, total versus ionized, is the entire theme of this section, because in critically ill patients, the total calcium will lie to you constantly. It's bound to albumin, shifted by pH, diluted by resuscitation. The ionized fraction is the biologically active one, the one your heart and your clotting cascade actually feel. When in doubt in the unit, Measure ionized. Let's build the box. Calcium below 8.5, but before anything, correct for albumin. Add 0.8 for every gram. Albumin sits below 4. A low albumin will hand you a falsely low total calcium in a patient who's actually fine. Causes. Post-surgical hypoparathyroidism is number 1. Think neck surgery. Then vitamin D deficiency, hypomagnesemia, causing PTH resistance, pancreatitis, rhabdomyolysis, massive transfusion via citrate, and hungry bone syndrome after parathyroidectomy. The symptoms are all about neuromuscular excitability, the Chvostek sign. Tapping the facial nerve makes the face twitch. The Trousseau sign. A blood pressure cuff inflated for 3 minutes triggers carpal spasm. Perioral numbness, cramps, tetany, seizures, a prolonged QT, and in the extreme, laryngospasm. Treatment. Severe or symptomatic gets IV calcium gluconate, 1 to 2 grams over 10 to 20 minutes, then an infusion. Mild and chronic gets oral calcium and vitamin D. Replace magnesium if it's low. If it's post-surgical, send a PTH. And note the target, 8 to 8.5, not full normal, because overshooting suppresses whatever residual PTH the patient has. Now the pearl that defines this whole section. In the critically ill, always check the ionized calcium. Total calcium is unreliable, with low albumin, acid-base shifts, or after big volume resuscitation. An ionized calcium under 1.1 means treat, regardless of what the total says. That single habit will save you from both missing real hypocalcemia and chasing a number that was never low to begin with. 3 hypocalcemia cases. And watch how each one turns on that total versus ionized distinction we just talked about. A patient who silently desaturated her parathyroids in the OR, a trauma code where the transfusion itself dropped the calcium, and a pancreatitis patient whose calcium was being sequestered in his own fat. Run the box. Let's go. Mrs. L, 48, total thyroidectomy for papillary cancer yesterday. Surgery noted as uneventful. Post-op, day 1, morning. She's tingling around the mouth and fingertips. The nurse documents, patient anxious, reassured. The surgical team says, expected. We'll check calcium this afternoon. By 2 p.m., she's in carpopetal spasm. By 4 p.m., laryngospasm requiring emergency intubation. The calcium, finally drawn at 2:30, comes back 6.8 total, ionized 0.72. Her PTH is under 2, where normal is 10 to 65. So in 7 hours, she went from tingling lips to a surgical airway emergency. Stop and think. After a thyroidectomy, when is tingling expected, and when is it an emergency? With a PTH under 2 and a calcium of 6.8, what is actually happening, anatomically and physiologically? And when you give the calcium gluconate, peripheral line or central, and at what rate? Let's be blunt. Post-thyroidectomy tingling is never expected until you've excluded hypoparathyroidism. A PTH under 2 means all 4 parathyroid glands were removed or devascularized in the operation. Without PTH, calcium can't be mobilized from bone, can't be reabsorbed by the kidney, and phosphate isn't excreted. So calcium falls, and phosphate climbs. And there's a relentless sequence of neuromuscular excitability you can watch unfold. Perioral tingling, then finger and toe tingling, a positive Chvostek, a positive Trousseau, carpopetal spasm, laryngospasm, tetany, seizures, and finally cardiac arrest. This patient marched through nearly all of it in 7 hours because nobody acted at the tingling stage, when the calcium should have been drawn within 2 hours. Now the route and rate, because this matters. For severe or symptomatic hypocalcemia, laryngospasm, tetany, and ionized under 0.9. Use a central line if you can, because calcium gluconate is a vesicant, and will cause tissue necrosis if it extravasates peripherally. If you only have peripheral access, use a big antecubital vein and dilute it. Give 1 to 2 grams over 10 to 20 minutes, slowly, because too fast causes bradycardia and AV block. Then follow with an infusion. And aim for an ionized of about 1.0 to 1.15, not full correction, because overshooting shuts down any residual PTH. The trap is that one sentence: some tingling is normal after thyroidectomy. It isn't. It delayed this diagnosis 7 hours and bought an emergency airway. Every total thyroidectomy, check calcium at 4, 12, and 24 hours. The pearl on agents, gluconate, for peripheral access because it's safer on extravasation. Calcium chloride, which has 3 times the elemental calcium, is for the code via central access. Mr. D, 22, polytrauma, hemorrhagic shock. In the trauma bay, pressure 60/40, heart rate 140, hemoglobin 4.2. Massive transfusion protocol activated. 14 units of red cells, 14 of plasma, 2 pools of platelets in the first 90 minutes. His pressure responds, the surgeon's satisfied, and he comes to the ICU stable at 90/60. But his cardiac output on the arterial waveform is dropping. His QTC is 580, and the nurse says his hands feel cold and stiff. The labs, total calcium 7.4, which looks almost okay, but ionized calcium 0.68, which is severe. Magnesium 1.1, potassium 5.8, temperature 34.2, pH 7.18. The trauma resident says, calcium 7.4, not that bad. Let's focus on warming and the pH. The ICU fellow asks, have you checked the ionized? Stop and think. Why are the total and ionized so far apart, and which one matters? What's the lethal triad of trauma, and how does hypocalcemia fit in? And how do you give calcium during massive transfusion, prophylactically or reactively? Here's the discrepancy explained. Blood products are anticoagulated with citrate, and citrate binds ionized calcium, forming a calcium citrate complex. So the ionized, the active fraction, plummets, while the total, which counts both bound and free, can look almost normal. And only the ionized matters. At 0.68, it's severe. It impairs cardiac contractility because calcium drives excitation-contraction coupling. It worsens coagulopathy because calcium is literally factor 4 in the clotting cascade. And it causes vasodilation. Normally, the liver clears citrate fast, but in massive transfusion, plus hypothermia, plus a hypoperfused liver, citrate piles up and the chelation persists. Now the lethal triad, hypothermia at 34, acidosis at pH 7.18, and coagulopathy. Each one worsens the others, and every one of them is made worse by hypocalcemia. So calcium isn't a side issue here, it's central. The rule: in massive transfusion, do not wait for symptoms. Give calcium gluconate, 1 gram, after every 4 units of product, or keep the ionized above 1.1 throughout. Warm all the blood, which both cuts citrate toxicity and fights the hypothermia. Replace the magnesium too. And don't reflexively bicarbonate the acidosis. It'll correct with resuscitation unless the pH is under 7.1 with hemodynamic compromise. The trap, common across trauma centers, checking only total calcium. It reads, acceptable, at 7 point something, while the ionized sits at 0.6 and quietly wrecks the heart and the clotting. Mr. W, 45, severe gallstone pancreatitis. Apache 2 of 26, CT severity index of 8. ICU day 4, and he's not improving. Fever of 39.2, white count 24, lipase still 4800. Then, during a nursing assessment, his hands lock into carpal spasm. Tetany. Calcium comes back 6.2 total, but his albumin is a low 2.1, so corrected that's 7.7. His ionized, though, is 0.81. Magnesium 1.3. The CT shows extensive parapancreatic fat necrosis. The team starts debating. Do we treat the corrected calcium of 7.7 or the ionized of 0.81? The resident plugs into the correction formula, gets 7.7, and says, "It's fine, no treatment needed." Stop and think. Corrected calcium 7.7, but ionized 0.81. Which one guides treatment, and why? What is saponification, and why does pancreatitis specifically cause hypocalcemia? And is a low calcium in pancreatitis a bad prognostic sign? Calcium above 10.5. And remember the 90% rule. Primary hyperparathyroidism and malignancy together account for 90% of all hypercalcemia. The split is clean and clinically useful. Hyperparathyroidism is the #1 outpatient cause, malignancy the #1 inpatient cause. So the PTH level splits your whole differential. PTH-mediated causes, high PTH driving it, include primary hyperparathyroidism, usually a single adenoma, then hyperplasia, the MEN syndromes, familial hypocalciuric hypercalcemia, and lithium. PTH independent, where PTH is appropriately suppressed, is led by malignancy through PTH-RP, lytic mets, or lymphoma-making active vitamin D, then vitamin D toxicity, and granulomatous diseases like sarcoid and TB, thiazides, immobilization, thyrotoxicosis, milk alkali. Treatment scales: mild, 10.5 to 12, hydrate, mobilize, treat the cause. Moderate, 12 to 14. Aggressive, IV saline, 200 to 500 milliliters an hour, and furosemide only after you've rehydrated, never before. Severe, over 14 or symptomatic. Add calcitonin, which works fast within hours, but fades in about 48, and a bisphosphonate like zoledronate, which is potent and durable, but takes 2 to 4 days to kick in. Dialysis for renal failure, and the symptom mnemonic: bones, stones, groans, and psychic moans. Bone pain, kidney stones, constipation and abdominal pain, confusion and depression, with polyuria layered on top. A calcium over 14 is a neurologic emergency. 3 hypercalcemia cases, and these are great because each one tests whether you can read the PTH, PTH-RP vitamin D pattern and land on the right mechanism. A confused man whose calcium announced his lung cancer, a sarcoid patient undone by a supplement, and a transplant paradox. Run the box? Let's go. Mr. K, 67, a smoker, no prior history, brought in by family for a week of confusion and not eating. They assumed depression. He's mildly dehydrated, and a chest X-ray shows a 4-centimeter right hilar mass. His calcium on admission is 14.8, ionized 1.72, and he's somnolent, GCS 12. The family mentions he complained of bone pain last month, but they chalked it up to arthritis. The workup: PTH suppressed, under 3. PTH-RP elevated at 12.4. That combination, suppressed PTH with elevated PTH-RP, is humoral hypercalcemia of malignancy. The intern says, calcium's 14.8, I'll start saline and order a bisphosphonate. The attending asks, how long does that bisphosphonate take to work? And what do you do in the meantime? Stop and think. With suppressed PTH and elevated PTH-RP, what's the mechanism? With a calcium of 14.8 and a GCS of 12, What's your treatment sequence and the timeline for each agent? And what do you check before giving that bisphosphonate? PTHRP, parathyroid hormone-related protein, is secreted by tumors, classically lung, breast, squamous cancers, and renal cell. It binds the PTH receptor and does everything PTH does, activates osteoclasts to break down bone and release calcium, tells the kidney to reabsorb calcium and wastes phosphate. But here's the crucial difference. PTHRP is not subject to normal calcium feedback. It just keeps driving calcium up, regardless of how high it gets. The patient's own PTH is appropriately suppressed by the high calcium, but the tumor's PTHRP is hammering the same receptor anyway. That pattern is your diagnostic key. Low PTH with high PTHRP equals malignancy. High PTH with low PTHRP is primary hyperparathyroidism, and low PTH with low PTHRP, but high active vitamin D points to granulomatous disease. Now the treatment timeline, because this is the attending's real question. Working in hours, saline at 2 to 500 an hour to expand volume and drive calcium out in the urine, plus calcitonin. The fastest agent, dropping calcium 1 to 2 points within 4 to 6 hours, though it loses effect after about 48. Working in 2 to 4 days, zoledronate, the most potent bisphosphonate. But check the creatinine first, because it's nephrotoxic, and you avoid it below a GFR of 35, and check the dental history, because of jaw osteonecrosis risk. And working over days to weeks, denosumab, if the bisphosphonate fails, or the kidneys won't allow it. The trap was the intern's plan. Saline and a bisphosphonate alone leaves a neurologic emergency untreated for 2 to 4 days while the drug loads. You need calcitonin now to bridge that gap. And don't give furosemide early, only after full rehydration, or you'll worsen things. Mrs. P, 52, biopsy-proven sarcoidosis on watchful waiting. 3 months ago, she started immune support supplements, including vitamin D3 at 10,000 units a day. Now she's admitted with fatigue, constipation, and polyuria. Calcium, 13.2. PTH, suppressed at 4. Her 25-hydroxy vitamin D is a toxic 310, normal is 30 to 100. And her 125-dihydroxy vitamin D, the active form, is markedly elevated at 180. Her PTHRP is undetectable, and her ACE level is up. The mechanism, in brief, sarcoid granulomas are packed with activated macrophages that express the same 1-alpha hydroxylase the kidney uses, and they convert vitamin D to its active form without any feedback control. The primary team says, just stop the vitamin D and give fluids. The sarcoid's been quiet for 2 years. Stop and think. PTH suppressed, PTHR, P normal. What's driving this hypercalcemia? Is simply stopping the vitamin D enough? And what else must you do? And why is this fundamentally different from hyperparathyroidism? The driver here is unregulated active vitamin D. PTH is suppressed. Feedback is working. PTHRP is normal. No malignancy. But the 125-dihydroxyvitamin D is high because the granulomas are manufacturing it from her vitamin D stores without any of the normal off switches. And this is why just stop the supplement is not enough. Stopping the D3 removes the substrate going forward, but 25-hydroxyvitamin D has a half-life of weeks, so the granulomas keep churning out active vitamin D from the large reservoir already on board. You have to actively shut down the production. How is this different from hyperparathyroidism? In HPT, high PTH drives the calcium. In sarcoid, PTH is suppressed and it's active vitamin D, boosting both gut absorption and bone resorption, doing the work. So the treatment: stop the vitamin D, avoid sun exposure, a temporary low-calcium diet, saline hydration with furosemide once she's volume repleted, and the key agent, prednisone, 20 to 40 milligrams a day. Steroids suppress that macrophage 1-alpha hydroxylase in the granulomas, shutting off active vitamin D production, and the calcium falls within days. Bisphosphonates, if it's severe or steroid refractory. The trap is, the sarcoid's been quiet for 2 years. Granulomas keep making that enzyme regardless of clinical activity, which is exactly why high-dose vitamin D is specifically dangerous in any granulomatous disease. Sarcoid, TB, histoplasmosis, lymphoma. The pearl, low PTH, RP, high active vitamin D, points to a granulomatous cause. Steroids work faster than anything else for it, and you have to order the 125 form specifically. Standard vitamin D panels only measure the 25-hydroxy form, so this gets missed all the time. Mrs. N, 58, end-stage renal disease, from diabetic nephropathy, on dialysis for 8 years. 6 weeks ago, she got a successful kidney transplant. Creatinine, now 1.2, GFR, 58, a great graft. But on follow-up, her calcium is 12.4, newly elevated. It was 10.1 before transplant. Her PTH is 820, down from 1200 pre-transplant, but still enormously high, and her phosphate is low at 1.8. No symptoms yet. The endocrine consult says, watch and wait 6 to 12 months. The mechanism, 8 years of dialysis and chronic low calcium, drove her parathyroid glands to hypertrophy and become autonomous. Now that a working kidney is absorbing calcium normally, the calcium rises, but the glands don't switch off because they've gone autonomous. Then, at week 8, calcium 13.1, creatinine creeping up to 1.4. The question on the floor, is the hypercalcemia damaging the transplant? A cinacalcet trial gets started. Stop and think. Why is the PTH still high when the new kidney works and the calcium is high? Is watch and wait appropriate? And what's the risk to the graft? And how does cinacalcet work? And when is surgery the answer? Magnesium. Normal range, 1.7 to 2.2. This is the electrolyte everyone under-orders and over-ignores, and yet it's the master key to the two cations we worry about most. You cannot fix refractory potassium or refractory calcium without fixing magnesium first. It's been the recurring rule all episode, and now it gets its own box. It's also, by some counts, the most common electrolyte disorder in the ICU. Let's give it the attention it deserves. Magnesium below 1.7, and it's strikingly common in the unit, present in up to 65% of critically ill patients. The causes: proton pump inhibitors, which are everywhere, diuretics, loop more than thiazide, alcoholism and malnutrition, GI losses, renal wasting from drugs like cisplatin, aminoglycosides, and amphotericin, and the insulin-driven shift during DKA treatment. But the consequences are why you care, and they're the through line of this whole episode. Low magnesium causes refractory hypokalemia because magnesium is required for the cell to hold on to potassium. It causes refractory hypocalcemia because magnesium is required for PTH to be secreted. It triggers arrhythmias, atrial fibrillation, and torsades, and it produces tremor, fasciculations, and seizures. Treatment: mild and asymptomatic, oral magnesium oxide, moderate, 2 grams of IV magnesium sulfate over 1 to 2 hours. Severe or torsades, 2 grams as a push over 1 to 2 minutes. Ongoing losses, a continuous infusion. Stop the offending agent and monitor the deep tendon reflexes during IV magnesium so you don't overshoot. And the Euboxia rule, stated one final time. In any patient with refractory low potassium or low calcium, check and replace magnesium first. You cannot fix them without it, and it's the single most commonly missed step in electrolyte management. Magnesium above 2.2, and this one is almost always either renal failure or something we did to the patient. The causes: kidneys that can't excrete magnesium, excess administration, think eclampsia treatment or magnesium-containing antacids, laxative abuse, adrenal insufficiency, and lithium. What makes hypermagnesemia clinically elegant is that the toxicity tracks the level in a predictable staircase, and the physical exam gives you an early warning system. 3 to 5. Nausea, flushing, lethargy. 5 to 7. Loss of deep tendon reflexes. And that's your alarm, because the reflexes go before the dangerous stuff. 7 to 12. Respiratory paralysis. Above 15. Cardiac arrest. So the loss of the patellar reflex is your canary in the coal mine. Check it, especially in anyone getting a magnesium infusion for eclampsia. Treatment: stop all magnesium sources. Give calcium gluconate, which directly antagonizes magnesium's effect at the membrane and buys time. Saline with furosemide if the kidneys work, and dialysis if it's severe or they don't. Throughout, monitor reflexes, respiratory rate, and oxygenation. Calcium is your immediate antidote. Dialysis is your definitive removal. Phosphate: normal range 2.5 to 4.5. Easy to overlook because it rarely makes the heart fibrillate. But phosphate is the backbone of ATP, so when it crashes, energy-hungry tissues fail. Muscles, including the diaphragm, and it's the electrolyte at the dead center of refeeding syndrome, which we've already seen nearly kill a patient. 2 boxes here, and the low one matters most in the unit. Let's go. Phosphate below 2.5 and severe under 1. The number 1 ICU cause is refeeding syndrome, and that's critical, so we'll come back to it. Other causes: antacids binding dietary phosphate, redistribution from insulin therapy, or DKA treatment, or respiratory alkalosis, malabsorption, hyperparathyroidism, and FGF23 excess. The consequences flow from phosphate being the substrate for ATP. When cellular energy fails, you get muscle weakness severe enough to cause respiratory failure, impaired cardiac contractility, hemolytic anemia from a fall in 2,3-DPG, platelet dysfunction, encephalopathy, and seizures, and in the extreme, rhabdomyolysis. Treatment: mild gets oral sodium or potassium phosphate. Moderate, oral plus IV if not tolerated. Severe or symptomatic, IV phosphate over 6 hours, and watch the calcium during replacement because phosphate and calcium precipitate together. Now the refeeding box, because this is the one that kills. Starting nutrition in a malnourished patient triggers rapid cellular uptake of phosphate, potassium, and magnesium, and the result can be fatal cardiac and respiratory failure. Prevent it exactly the way we discussed in that anorexia case. Start feeds at 10 to 20 calories per kilo per day, and supplement electrolytes aggressively for the first 2 to 3 days. Slow and supplemented is how you refeed safely. Phosphate above 4.5, and the dominant cause, far and away, is renal failure, because the kidney is the main route of phosphate excretion. Other causes: hypoparathyroidism, tumor lysis syndrome, rhabdomyolysis, excessive phosphate from enemas, and vitamin D toxicity. The key consequence to understand is the calcium-phosphate relationship. When the product of calcium times phosphate climbs too high, the two precipitate out of solution together, so hyperphosphatemia drives hypocalcemia, and worse, it deposits calcium phosphate in tissues. That's metastatic calcification, and in its most feared form, calciphylaxis, vascular calcification that's painful and often lethal. You also get secondary hyperparathyroidism and pruritus. Treatment: restrict dietary phosphate, Use phosphate binders with meals, calcium carbonate, sevelamer, or lanthanum, with the binder timed to the meal so it traps the phosphate in the gut. Cinacalcet for the secondary hyperparathyroidism of chronic kidney disease. Dialysis in end-stage disease. And treat the underlying cause, which in the acute setting often means managing tumor lysis or rhabdomyolysis. Binders with meals, dialysis for the failing kidney, that's the core. Chloride, normal range 98 to 106. The forgotten electrolyte, the one most people glance past on the panel. But chloride is quietly powerful. It usually tracks sodium, but when it diverges from sodium, it's telling you something specific about acid base. Learn to read that divergence, and chloride becomes the tool that closes your diagnostic box. Let's give the forgotten electrolyte its due. Chloride mirrors sodium most of the time, but in acid-base disorders, it splits off. And that split is the whole point. Start with low chloride, under 98. Causes: vomiting, NG suction, loop diuretics, metabolic alkalosis. The mechanism worth knowing is contraction alkalosis. As you lose chloride, the kidney retains bicarbonate to keep the anions balanced, and the patient turns alkalotic. There's also cystic fibrosis with its urinary chloride wasting. Treatment is chloride-rich saline, and the single most useful test here is the urine chloride. Under 10 means saline responsive, give volume, and it resolves. Over 20 means saline resistant, a different problem entirely. High chloride, over 106. The number one ICU cause is normal saline overload because saline has far more chloride than plasma does. Pour in enough, and you get a hyperchloremic, non-anion gap metabolic acidosis. Other causes are renal tubular acidosis and diarrhea. The fix for saline-induced hyperchloremia is to switch to balanced crystalloids, lactated ringers, or plasma light. Now the part that makes chloride a thinking tool, the anion gap. Sodium minus chloride plus bicarbonate, normally 8 to 12. A high gap means unmeasured anions, lactate, ketones, toxins, uremia. But a normal gap with a low bicarbonate is a hyperchloremic acidosis, and now you go one level deeper with the urine anion gap, sodium plus potassium minus chloride. If it's negative, the kidney is appropriately excreting acid, so the loss is from the gut, like diarrhea. If it's positive, the kidney is failing to excrete acid. That's a renal tubular acidosis. So chloride, the electrolyte everyone ignores, ends up being the one that closes the acid-base box. Here's the whole episode on one slide. The box, complete. Let's run it down. Low cause and treatment, then high cause and treatment for each. Sodium. Low. Think SIA, DH, and hypovolemia. Treat with fluid restriction or 3% saline, capped at 8 points a day. High. It's a free water deficit or DI. Replace free water at no more than 10 points a day. Potassium. Low. Diuretics and GI loss. Give potassium chloride plus magnesium. High. Kidney injury, ACE inhibitors, or acidosis. Calcium to protect the heart, insulin and dextrose to shift, and a binder to remove. Calcium. Low. Hypoparathyroidism, or vitamin D deficiency. Give IV calcium gluconate, or oral calcium and vitamin D. High. Primary hyperparathyroidism, or malignancy. Treat with saline, a bisphosphonate, and calcitonin. Magnesium. Low. Proton pump inhibitors, diuretics, alcohol. Give magnesium sulfate. High. Renal failure, or iatrogenic. Calcium gluconate and dialysis. Phosphate. Low. Refeeding, antacids, DKA treatment. Replace slowly. High. Chronic kidney disease or tumor lysis. Binders and dialysis. And chloride. Low. Vomiting, NG suction, diuretics. Saline and treat the cause. High. Saline overload, RTA. Diarrhea. Switch to balanced crystalloids. That's the entire box. 6 electrolytes, both directions, cause and cure. Notice the threads running through it all. Magnesium underwriting, potassium, and calcium. The relentless emphasis on correction rate for sodium, the total versus ionized trap for calcium. This single grid is your 3AM reference. Screenshot it. That's Episode 1. 6 electrolytes, 18 ICU cases, 1 consistent way of thinking. The box. If you take one thing away, let it be this. Almost nobody misses these diagnoses because they're rare. They miss them because they didn't look systematically, or they trusted a number without asking whether it was even real. Run the box every time and the misses disappear. Next time, in Episode 2, we take the exact same approach to the discipline where systematic thinking matters most of all, acid-base disorders. Until then, think inside the box. I'm Daniel Rusu. Thanks for listening.